house and everything too. So one of the things we do too, when we come back from a job, we have to clean all of our equipment. We want to clean ourselves, but we want to clean the apparatus and anything that's contaminated. So we want to do that. So think about in those terms what you can do. You can avoid, practice good hygiene after, clean up if there's something that might have been on you. Clean. Be smart about that. And also now you're looking beyond that, taking care of you, making sure you get your annual physicals, because a blood test could determine some things. It might be that red flag that you need. If you're having any kind of symptom, follow up with it. The symptoms that you had it was great that you went to do something about it. And if it's a respiratory symptom, it may seem like it, follow up. Could be a cardiac issue too. So it's you taking care of it. As Dr. Marr said, be your best advocate. Who better to advocate for you than you? And don't be afraid. Don't be intimidated. Doctors, and they may not try to be intimidating. Maybe some of them are. But be your own advocate and don't back down. And now we have AI. We have so much information. Use it. Use it for you, the best reason, and your family as well if you're seeing something. So follow up. Avoid things that'll give you cancer, whether it be lung cancer or any other kind. Clean yourself if there's something going on, if you're contaminated with anything. And contaminated means something spills on you. It could be that simple. Do the simple things you need to do. And they add up. And also then follow up medically. If you can do that, you're going to be your best advocate and do what you can do. You can't do everything, but the things that you can, that you are in control of, if you're able to work those in your favor, you'll be better off for it.
Captain King, can you just share a little bit about if I'm in a house fire, exposures?
So as a firefighter or as a person? So I was asked to just talk about if you're in a house fire, what you're exposed to. At that time, the worst thing you're exposed to is heat and smoke. And you want to get out as fast as you can. If you're in a house or an apartment that there's smoke showing, you want to, before this happens, again, we want to prepare before, how am I getting out of here if there's a problem? Okay, so you want to enact that plan and get out as soon as possible. So what happens now, and now, like I said, I've been on this job 34 years now, so when even back then, a lot of plastics are involved with furniture. Everything now is plastic-based for the most part. Very few natural wood ingredients. So when that stuff burns, that's all chemicals. It's basically gasoline and oil burning. So all those things are now going to be particulates in either a gaseous form or solid form as particulates, and you're going to be breathing them in. And you want to get out of that environment as soon as possible. Best thing you can do at that time is get as low as possible, because the fresher air is going to be low. Okay, and again, you're getting out. Call 911 from outside. Get everybody out of the house and stay out. Have your plan beforehand. Smoke alarms. If you don't have smoke alarms in your house or apartment, call 311. The landlord's supposed to get them. I never said no because it was the landlord that should do it. I put them up anyway, and most of the guys will too. Call 311 for smoke alarms. Practice it's not a fire prevention speech, but be smart and do what you're supposed to do. 311 if you need smoke alarms. Get out, stay out, and live another day. And that's what we want to do. We want to live our lives in as safe, as good as possible. And
thanks, Chief.
You got anything else?
Thank you very much, sir. Thank you. And I think equally important for those of you who are smokers, we always hear about primary smoking, what we take in ourselves, and there's something called secondary, which we'll hear about later on. Those are people around us who are breathing in the smoke, but there's this thing called tertiary smoke. And what that is a material that settles on the furniture, on the curtains, and on the rugs. And the same toxins that we're breathing in, you're exposing people to that. Think about little babies crawling around hand to mouth. So that's another thing we have to consider. Just like the chief said, they want to get rid of all the contaminants off their clothing. We have to make sure we get the contaminants out of our house. Next, I'd like to bring up Ms. Shanika Bond, who's the Regional Director for the HEAL Collaborative and Coordinator for today's program.
Good Good morning, everyone. Welcome to Heal Collaborative's Lung Cancer Screening to Treatment 2.0 program here at Mount Airy Church of God in Christ. To those of us that are joining us today for the first time, welcome. To those of you who are watching virtually, welcome. And to our Mount Airy family, it's good to be back, always. My name is Shanika Bond. I serve as the Regional Director of Community Outreach and Advocacy Engagement with Heal Collaborative. Our mission is to increase awareness, improve access to care, and empower communities through education, advocacy, and collaboration. Before we begin, I would like to extend my sincere appreciation to our sponsor, Amgen, for their generous support for today's program. Today's educational content was developed independently by Heal Collaborative. I also want to thank Bishop J. Lewis Felton for his leadership and for opening up the doors of Mount Airy Church of God in Christ to this important initiative. We're also grateful to Mount Airy Church of God in Christ Kingdom Health Awareness Ministry and their coordinator, Dr. Charlotte Morris, for our partnership and commitment to improving the health of our community. Today's program is about education, empowerment, and action. Lung cancer remains the leading cause of cancer-related deaths in the United States, but early detection through screening can save lives. Our goal today is to provide you with the knowledge, resources, and connections needed to move confidently from screening to treatment and beyond. So whether you're here today joining us in person or virtually, thank you for being here.
Thank you very much, Shanika. As a surgeon, I like to believe that patients take in everything I say and follow my advice 100%. If you can judge by the laughter, we all know the truth. Often the most impactful advice tends to come from patients' families, friends, community members, church members, and neighbors who have themselves been on that journey from diagnosis to treatment. Today, Ms. Shamika Williams, a lung cancer survivor from Princeton, New Jersey, will share her story and give us the patient's perspective. Ms. Williams, please.
Okay, good morning, everyone. It is truly a blessing for me to be able to be here with you today. And I call it a blessing because I've survived for 4 years now. I'm going to share my story with, thank you. I'm going to share my story with you, and I'm going to actually start in 2006. My story actually starts with my mom. 2006, we're celebrating Thanksgiving, and everything is great. And then my mom says she didn't feel well, and she went to the hospital. A few days later, they tell my mother she has a mass in her left lung, and that the mass was cancerous. And so, of course, that significantly changes the life of our family to hear this type of a diagnosis of our beloved mom and mother and the person who holds everything together for our family. So, we had to deal with that, and we had to start that journey with my mother. My mother went through a lot during her time, and she lost her battle less than a year later. So a day before her birthday, before she turned 61, my mom, Carrie Mae, passed away from complications. But now, let's fast forward, because I'm going to kind of keep telling you some dates just for you to understand how important speed is, especially when it comes to cancer. Fast forward to July 2022, and just for you to get a perspective of what was happening in the world at that time. We were in that transitional space during the COVID era. In July, we were starting to go back to work. We were beginning to travel again. And my job sent me to Orlando to participate in a conference. Now, at the conference, we were wearing masks. But the conference that we went to was in Florida. And a lot of the people in Florida didn't want to wear masks, whether it was, right in the midst of COVID or whether we were at the end of COVID. But anyway, I attend the conference, I do what I need to do for my job, and I come back and I realize that I have contracted COVID. I was annoyed because I was like, oh my gosh, I got COVID now. I got to stay home for a week. Well, I get COVID. I reach out to my primary care physician. She starts to give me the care for COVID. I've been working with my primary care physician for over 20 years, so we have a really good relationship. So I get the medication for COVID. And a couple of days later, I'm brushing my teeth. And I coughed, because I started coughing with the COVID and everything, right? So I'm brushing my teeth, I started coughing. And I spit out into the toilet, and I see blood. And I said, my gums are bleeding pretty badly today. So I continued to brush my teeth, rinse my mouth out, went about my day. Started my day. Well, a little while later, I cough again. And I go to the bathroom and I taste blood and I spit out blood. And then I go, that's interesting. That's happened twice. And then the third time, because this was all within probably like an hour and a half, I saw the blood again and I tasted the blood. And I called my doctor back. And I said, hey, doc, this COVID is not clearing up. I'm coughing up blood now. And she said to me, Shamika, coughing up blood is not a sign of COVID. Go to the hospital. Tell them I want a scan. So I go to the hospital. And while I'm there, before I go, I tell my sister where I am, because my sister is my ride or die, and I'll tell you about her in a little bit, right? So I was like, hey, I'm about to go to the hospital. My doctor wants me to go. I'm coughing up blood. And she's like, what are you talking about? I'm like, girl, I just got to go. I'll call you back later. Go to work. So I go to the hospital, and I get there, and they're like, are you sure you're coughing up blood? I was like, yeah. So for the hours that I'm there, every person who came into the room said, are you sure you're coughing up blood? So I got a little bit annoyed. And so what I started to do was, they had a little box of tissue there. Every time they would ask me, I would take a piece of tissue and I would cough in the tissue and hand it to them. Since you don't believe my symptom is real, or whatever is in your mind, or whatever you're believing, I want you to see the authenticity of the blood that's coming out, that I'm coughing out. So I began to give everybody a gift when they came in and asked me the question. So finally, they give me the scan that my doctor wanted me to have. And a little while later, a doctor comes in, and she's the ER doctor, and she says, Ms. Williams, I'm concerned about what I'm about to share with you, but we see a mass in your left lung. Now, if you remember, my mother's mass was in her left lung. And by this time, my sister hasn't made it to the hospital. She's in the room with me, and I look at the doctor, and I look at my sister, and I said, we lost my mom to lung cancer, and her mass was in her left lung. And I looked at my sister, and I knew my sister wasn't, ride or die with me, but my sister was trying to maintain her composure. And the doctor said, well, we're not going to say it's cancer today. We want you to see a specialist. We're going to keep you overnight, and then you'll see the specialist tomorrow. So, we're in a house of faith. So I looked at my sister, and I said, listen, I want you to go home and get some rest. You've worked all day. You're tired. Go home. There's nothing you could do for me. I just got to wait for the specialist to come in. My sister, who never leaves my side, said, okay, let us pray. My sister prayed with me, and my sister left me in there alone. And I was like, okay. She left me alone, but I wasn't by myself. So in that moment, I realized that I needed my time to be with my Father, to talk with him about what his word says about me. And so over the course of my life, Proverbs 3:5-6 has been a critical scripture that has been over my life. To trust in the Lord with all your heart and lean not into your own understanding. In all your ways acknowledge him, and he will direct your path. So I talked to him about that, and I was like, you've been telling me this all my life, Lord. And then he reminded me of being anxious for nothing. So we were just having this conversation overnight while I was waiting for this specialist to come in. And the specialist finally comes in the next morning. So after my conversation with God, it happened all overnight, the specialist comes in. And he goes, Ms. Williams, from what I see, this just looks like an infection. I'm going to give you a Z-Pack. You go home, get an appointment with me in a couple of weeks, and then we're going to follow up there. But I'm still coughing up blood. So I'm like, okay. we were celebrating my nephew's birthday that weekend. So I celebrate, not his birthday, his wedding. So I went to his wedding. At my nephew's wedding, I'm coughing up blood. No one in the family knows this, right? So that week, I called his office. I'm trying to get an appointment. I couldn't even get through this particular specialist that that particular hospital connected me with. I finally get through, and they say to me, well, we can't book any appointments right now. We're going to try to maybe book you at the end of the month, maybe next month. They didn't even book an appointment with me. So, again, I have a great relationship with my primary physician, and I think this is important. She and I are chatting, and I say to her, I can't even get an appointment with this guy. And then she says to me, you know what? I could call somebody at Fox Chase. Do you want to go to Fox Chase? And I said, Fox Chase, the cancer center? Because for me, if you live in this area, you see that commercial all the time. And I was like, she said, you know, let me know if you want to go, and I could try to see if I could get you an appointment. She said, I want to rule that out for you. I said, okay, well, we're going to rule this out. Okay, I'll go to Fox Chase. She gets me into Fox Chase within a couple of days. That doctor said something very different. He says, I'm concerned, and I want to do another follow-up test. And they do what they call a bronchoscopy, where they were testing the mass that they see in my lung. A couple days later, he calls me back, and I'm on the phone with a couple of friends. And he says, Ms. Williams, I want to let you know that we got the results back. And I see a carcinoid in there, but we can get this out. We need to get a surgeon, da-da-da-da-da-da. And he starts talking about a plan of care. And I was like, excuse me, doctor, you're saying carcinoid. I said, I recognize that I work in the life sciences industry, but I work in HR. When I hear carcin, I think of carcinogens, and I think of cancer. Are you telling me that this tumor is a cancerous tumor? And he paused, and he looked at it, and he said to me, I'm sorry, Ms. Williams. Let me take a step back. I started talking scientifically. Yes, you have a cancerous tumor in your lung, and we need to move to get it out. And then it got real. My friends who were on the phone with me, we hung up with the doctor. Oh, I'm sorry. I didn't realize you couldn't hear me. Thank you. So my friends who were with me, they said, did you understand what he said to you? What can we do? And I said, well, for now, there's not anything we could do. He said, we got to start doing these things. So then we start to do the plan of care. We start going for all the tests. We identify a surgeon. I go to see a surgeon. They tell me that it's early, and it's in the early stages, and my prognosis is good. Prognosis good is one thing, but you're still scared when somebody tells you you have a cancerous tumor in your lung and you lost your mother to lung cancer. So we go through the process, and I go through the surgery. And by God's grace, they were able to surgically on November the 2nd remove the tumor from my lung, and was able to get it all out once we were able to do the surgery. So thank God, right? They were able to get it all out. And one of the things that I do want to share is that I understand, because I've worked in the life sciences industry, how important clinical trials are, and our community sometimes has a bias about that. But I donated my lung tissue because in talking with the person that I spoken with, they said they were trying to create tests that potentially they could go and be able to do treatments, do a testing that they could test you for lung cancer versus you waiting for these types of symptoms. And so I donated my tissue so that it can go to be researched, and we could get some early treatment. So fast forward, they removed all the cancer from my lung. I am now on an annual screening path where they check me every year, and they do a scan of my lung every year. And I just had my 4th year of being cancer-free. And so why I do this is I do it because I care about the community. I want people to get early diagnosis and treatment. The faster you work, the faster you can have a positive outlook. Fast forward, I'm now traveling the world. I've started my own business for HR, and I'm doing things to impact the community that's important to me. So I just wanted to make sure that you understood that early detection is important, advocating for yourself, following up, checking for a second opinion is so important, and that is why I'm here today to share with you that you still have options. Cancer does not have to be a death sentence. It just means that you have to do some work now and start a journey. So thank you for your time, and I'll be here later.
Thank you very much. Again, that's one of those interesting stories that reminds us we have to be responsible at the end of the day for what's going on with the help of the care team, but we are the center of the whole thing. I want to remind you that, again, the care access people are out here doing blood draws, looking for renal as well as cardiac disease. So if you're concerned, I do advise you, take a chance to stop out there. They're the first door to your left. Our first speaker is going to be Dr. Eric Flanall. Dr. Flanall is an associate professor in the Department of Medicine at the Morehouse School of Medicine in Atlanta, Georgia. He is the chief and director of pulmonary and critical care and interventional pulmonary medicine at Grady Hospital. He's also the director of the Georgia Cancer Center, Advanced Diagnostic and Interventional Pulmonary Service, and he's also the director of the Lung Nodule Clinic at Grady Hospital. See, if you had a chance, you're going to go down there to Atlanta to see somebody like him. He'll take good care of you. Dr. Flanall.
Good. And I'm going to remove this so I could walk around and give the cameraman a heart attack. All right. Got you. So I'm going to run really quick through getting an understanding of what happens after a diagnosis or something suspicious is seen on a screening. However, how many were here last year at the last year's one? Okay, great. So there's a few people that are new. I'm going to give a quick recap through some of what we went through because this is going to be part 2 of it. Okay. So, quick recap. I do want to re-emphasize exactly what lung cancer is, okay? So you take a normal cell, and it doesn't necessarily have to be the lung. It can be the colon, prostate, whatever else. But from that normal cell, there's a genetic change, and it makes these cells grow out of control. They have no limits to what they do, and they do what we call as a doubling. So you have one cell to go to 2 cells go to 4 cells, and over that time, it takes over organ systems, and it becomes a malignant cancer. That's any type of cancer. Specifically, what we're talking about is lung cancer. And we're looking at some of the lung cancer health disparities. And when I think about the disparities, and I think the first time I focus more so on the health and this health care, there's an imbalance that occurs that causes disparities, right? So when we talk about health, we talked about the environmental exposures and the biologies, especially to specific populations, right? And today I'll focus a little bit more on the healthcare system and how that impacts some of the disparities. But just quick recap, we know number 1 cause, don't have to show you this slide, is smoking, correct? Number 2 is radon. I don't think people realize this as much, but radon's the number 2 cause of lung cancer. It is a radioactive material, comes out of the soil, whether you're near factories or your granite. It's a breakdown product of uranium. Doesn't have a smell, doesn't have a taste, doesn't have a color. It collects in the house, causes changes in your DNA, and that's how the lung cancer develops. Interesting, it is the number 1 cause of lung cancer in people who have never smoked. So keep that in mind. If there are people that are coming up with lung cancer or other types of cancer, they've never smoked or don't have any exposures, you might want to get your house tested for radon, because here in Pennsylvania, of those houses that are tested, 39% of those are above the EPA's recommended safety levels, right? And you got to think, who lives in these housing areas where the risk of lung cancer is highest? So keep that in mind. And then there's other things, asbestos, pollution, chemical factories, and just having lungs. You don't have to have smoked or been exposed to radon just to develop lung cancer. Just the fact of having lungs, some of the natural changes can occur with that. All right, so just to recap on some of the healthcare disparities and why specifically lung cancer is worse for African Americans, because despite smoking the same, they're more likely to develop lung cancer. So what you're looking at here is you're looking at the incidence rates per 100,000, just focus on the the levels here. So African Americans, their likelihood of, or their incidence rate of developing lung cancer is 74.7 versus whites that are 64, and then Native and Alaskan Americans, which is 44. So you can see the difference here, higher risk, but now these are the smoking prevalence here. So this is men, women for African Americans, men, women for whites and Native Americans. You can look 25 versus 23. It's about the same smoking rate for men. And for women, 18 versus 20. It's about the same. But now come back over here and you see that it's significantly higher likelihood of developing lung cancer. And then if you take a look down here where Native American men and Alaskans are smoking almost twice as much, they're about 30 points less on developing lung cancer. So what does this tell us? This tells you that there's something different about the biology, something different about African Americans that makes them more susceptible to the bad effects of tobacco smoke. And so we got to keep that in mind, because this is what accounts for some of the difference we see. If we look at the new estimated new cases of all the types of cancer that we expect to see this year for African Americans, men, women, you can see that prostate's number one. There's about 3 times as much prostate cancer we expect to see this year versus lung cancer. And for women, we'll come down here. Look at the deaths though. Even though you have 3 times as much prostate cancer, you're more likely to die of lung cancer. For women, you have about 3 times as much breast cancer, you're more likely or equally as likely to die of lung cancer, right? So again, there's something about the bad effects and how the cancer behaves in different populations that plays a role. Okay. One of the things we talked about, and I reiterate this every time, if we know smoking's number one and we know there's bad side effects or increased risk from smoking in different populations, we have to pay attention to the smoking aspect of it. And what I've learned over the years is when I see a patient, I ask them about, okay, I ask them, how much do you smoke and when did you start smoking? What else do I now have to start asking? What do you smoke? Yes, do you vape? Do you use marijuana? And what I think people don't really understand is that it's not the nicotine and smoke that causes the cancer. Okay? It's the other 3,000 to 6,000 chemicals that are put into it that are burning that are what's causing the genetic changes, the formaldehydes, the benzenes that get released. And that's what causes the difference. But nicotine keeps you going back. It's an addiction. We just have to say it's an addiction that keeps you going back even though you know it's bad for you. If it were a new drug on the market today, the FDA would have a big problem with it because the only 2 things more addictive are heroin and cocaine. But, politics and money has allowed it to get a little bit of a pass, but it's tightly regulated. So tightly regulated that we know about every cigarette has about 8 to 10 milligrams of nicotine in it. So when we look at the other things that people are smoking, we can make this estimate of exactly what their cigarette equivalent they're getting. So you see people that are smoking the Black & Milds and the Swisher Sweets and those small cigars. They have about 100 milligrams, each one of those, of nicotine in it. That's about 12.5 cigarettes. I had a 34-year-old guy. He had stage 4 lung cancer. He says, Doc, I only smoke 4 a day. I said, 4 what? 4 Black & Milds. I said, you're a 2-pack-a-day smoker. Do you realize this? This is the equivalent of what you're inhaling. And the large cigars, they're about, 25 cigarettes. So you're over a pack just with one of those. And it's sort of that understanding, we have to have that understanding, that knowledge part of what we're putting in our bodies before we can make a difference and make a change. But the tobacco companies know this, and they advertise to African Americans higher. And we know this because this Black & Mild name is not by coincidence. The battery go? Let's go. Can we do the next slide? My battery's dead. There we go. All right. Now the vapes, right? We know pack of cigarettes has how many cigarettes in it? Yeah, you shouldn't know that. Okay, good. All right, so we know 20 cigarettes in that, okay. So now you start to see these pods and you drive by somebody and there's a big old plume of smoke coming out, right? Right? Each one of these pods have a different equivalents, right? The jewel pods, that's about 41 cigarettes. People go through 3 or 4 of these in a daytime, right? The puff bar, which they put the menthol in, okay, to make it smoother so it doesn't irritate you and you keep going back, is about 50. And the Surin pod, I just really think they need to take that off the market. Because there are people go, yes, it's about 90 cigarettes. Yes, yeah, right. And you think about that. It's not only that, but it's the secondhand smoke. Because when you're around these people and they're blowing out these big plumes, you're getting a secondhand smoke of that too. The hookah bars, right, has become now a trend. We're going to go out, we're going to go hookah bar, sit around. They're going to bring this little thing out, and we're all going to pass this little thing around and inhale on it. So look, I tell everybody this too. If my friend gives me a drink, they say, oh, this tastes good. Here, look, I'm looking at that straw a little sideways there because I don't know where your mouth has been, right? But you got a group of them. They'll rent one of these or get one of these for an hour session. Each one of them's passing around. You got all the secondhand smoke around. You get about 200 puffs per session. That's about 100 cigarettes per session, okay? That's 5 packs in one session. Now, does that mean they're going to get addicted right there? No, but what does that do? That tells you that this is socially acceptable for young people who are getting the high off of the nicotine, and it is an encouragement, and that's where the problem starts. And then there's this. Right, and so we didn't know in the past how much marijuana contributed to developing lung cancer, but now we know. With legalization, we'll be able to get studies and really exemplify. And we know that heavy cannabis users, they have a 2-fold risk of developing lung cancer. So the question is, what's a heavy user? Then that study was 50 times in a lifetime, okay? Not a week, because we know some people, right? 50 times in a lifetime puts you at a 2-fold risk of developing lung cancer. So those are the factors that played a role into the health and the biology and environmental exposures that we were able to, that we should be able to make a difference in by just through education and changing how our practices are in our exposures. I want to move forward for this talk to talk about the healthcare side of the disparities. What's contributing there? And part of this is screening and early detection. We heard the stories today. You found something, something doesn't seem right, but was there a delay in getting it detected? And then moving through the system, whether that system's not moving fast enough for you or you're not moving fast enough for the system or things aren't just available. But those also contribute into some of the disparities. So you're going to hear more about screening, so I'm not going to spend a long time of it, but we do know that when we screen for something, we are trying to find a disease before it causes problems, right? Before there are symptoms. And the secret about lung cancer, I'm going to give you your anatomy class right here, is that in the lungs, you ever hear somebody that bruised their ribs or bruised their lung, right? There's a lot of nerve fibers along the edge of the lung, right? And so that's a lot of pain that will come there. Or somebody will have a cough or they're coughing up blood. That's because there's nerve fibers inside your airways. But in the tissue of the lung, which is here, there's no nerve fibers. So this little spot, that little early lung cancer can grow undetected. And that's if we catch it that early, that's the best chance you have for survival, right? So we want to catch it before you have those other symptoms. And we know that getting a yearly CAT scan, and you'll hear about it, is a lot better than just getting an X-ray, especially if you qualify for it. And that if you do this screening process, you have about a 25% less chance of dying of lung cancer. So you'll hear the criteria. They're going to go through this more. But the general criteria is if you're between the ages of 50 and 80 and you smoked what's a 20-pack year history, which is a pack a day for 20 years or 2 packs a day for 10 years or more, then you would qualify for the screening. Okay? It's really important to know that. But here's something that we need to know, especially for the populations that we see that are at risk, is that 25% chance less of dying of lung cancer if you get screening, but for African Americans, if you get screening, it's even better because that number jumps up to 39% fewer chances of lung cancer deaths. So it's more impactful, but you think about that. We already know the bad effects of tobacco smoke cause cancer more, so it would make sense if you screen more aggressively, you could decrease that. How many here, just a show of hands, how many here even knew that there's any screening for lung cancer before coming here? Right. Most studies show that 50% of people who are eligible for screening don't even know that there's that opportunity here. But we do know that if we do screen, that it closes those disparities, especially in early detection. Because if we look over here, you'll see that blacks are in the light blue and whites are in the darker blue, right? Less likely to get an early diagnosis. And if you don't get the early diagnosis, you're less likely to get surgical treatment, which is often the best treatment and cure, as you'll testify to. And then the survivals, you're less likely to survive after 5 years. Yes, ma'am.
So, just personal experience.
Can we hold on?
Yeah. Oh yeah. Oh yeah. Oh yeah. Yeah. Time wise. Okay. Yeah. I'll keep going, and then we promise we'll come back to you. Okay. Thank you. All right. So what happens after you have an abnormal screen? Well, a lung nodule. When you hear lung nodules, it's the spot that we see on the scan. That's all it is. It's the spot that we see on the scan. Little bitty tiny thing. About 95% of these are harmless, right? They might be a benign infection, scar tissue, just normal tissue growths, abnormal tissue growths. The other 5%, these are the malignancies, whether it's a single lung cancer, or it's something that's come from another part of the body, and sometimes it could be a progressive scar tissue or a lung disease process. But what the doctors need to do is we need to identify exactly what we're looking at through a specialist preferably that deals with this and decides it's solid, is it growing, is it hazy, and then we figure out what the follow-up and the next steps are based on those characteristics. Okay. So when we see something, we think, okay, this really does have an appearance on the scan that it could be a cancer. And I say this specifically, and I always tell my patients the same thing too. What we see on the scans doesn't give you a diagnosis, right? We don't know. They're only pictures. It's only until we get tissue. So we need to find out what is there. When there is something seen, that we have a whole process that improves the outcomes. You get linked with a navigator to get you through this process. And a patient navigator, this is a trained guide. You'll hear about this, right? And we found that this person will navigate you through this whole, this whole complex road of getting to a diagnosis and getting you to treatment, because that's what they're trained to do. And especially in the communities where income is low, or someone's homeless, or they don't have rides, we find that if you add a navigator to that, then there's almost 5% or 5 times the likelihood of success of getting through this process. Okay, and that programs with navigators, they increase the success rates for at-risk communities by 25%. So this is crucial if you have an abnormal finding. Navigating. How do I get to the next appointment? How do I get through the next steps? And these people are trained to help you. But the goal we want to get when we see something abnormal is we want to get to a tissue diagnosis. We need a biopsy. Now, biopsy could be a surgical biopsy. It doesn't mean it's surgery. Sometimes we just come with a needle across. If we can get into it, numb you up, and get a needle in there, get some of the cells and look underneath the microscope. Or we can go with little camera scope, a bronchoscopy. And we can guide ourselves to this area even remotely and get samples from there. And then that's looked at with a team of specialists, right? So when we have what we call our tumor boards, we have the tissue, we have all the scans, we have a radiologist, we have a pathologist, we have a pulmonologist, we have the surgeons, the radiation doctors, and we're all in a big room looking at everything we see to see what the next step is. And we communicate that with the navigator who's also in the conference with us, and they help us get to that pathway. So after a cancer diagnosis is confirmed, we got to keep this in mind because I've had this happen a few times, okay? I'm coming back to the biology of this a little bit because I want to talk about this thing right here, this doubling time. And what the doubling time is the time it takes for that one cell to go to 2 cells and 2 cells to go to 4 cells, okay? Or think about this. If you had something the size of a grape, that time it takes to be the size of 2 grapes and then 4 grapes, because that's the rate that we want to. So when we get a diagnosis, we want to make sure that we are not delaying it. Sometimes patients say, I don't like that you give me that diagnosis. Well, we looked at it underneath the microscope. We know that's what it is. I'm going to get a second opinion. So then you go out, you get another appointment, then they got to do another biopsy, then they got to do more follow-up, stuff like that. And by that time, a month or 2 has gone by. So some of the cancers differ, right? The small cell cancer, which I didn't go deep into right now, takes about 30 days before it doubles. Okay? The non-small cell, the adenocarcinomas, the squamous cell carcinomas, that's between 60 and 90 days. So if you're putting all this off 2 to 3 months, you're allowing it to double, right, and delaying things. So that's where the navigator helps you, right? They move you through this process. Because then once we know this is cancer, our goal is to get to staging. And all we're doing with staging is trying to figure out how far it's spread, how big it is. Okay? Because these make a difference. Okay? So if we can catch it in early stage where it's small and it hasn't spread anywhere, there's about 65% chance of somebody still being alive in 5 years. Okay? If it's in the late stage, it drops down to 9%. Right? And so because we don't have all these processes with screening and these navigation process, we often find that minorities are often diagnosed at a later stages, which limits the opportunity for the treatments that they can get. Treatments primarily focus on 2 main things, right? The traditional treatments, if you can cut the cancer out, get it out of the body. That's the best thing, okay? If it is not at that point, then you may have a combination of maybe some chemotherapy or radiation or all 3 of them combined. Now there's newer what we call precision medicine, where we have targeted therapy for the specific cancer. I'm going to talk about that in just a second here. But let me go back here. So if I take, let me go back one. If I take black men, black women, white men, white women, and you have an opportunity for surgery, who's less likely to get the surgery? Thank you. Yeah, yes, exactly right. And I'm part of that part. But it's significant. It's significant. About 65% versus 90% of all of them getting the treatments available. This is where the communication and the navigation needs to help to get them to that point. Because if we're looking at a population to target, it is that targeted population right there, because they're most at risk there. Precision medicine, it actually works, and let me give you an idea about this. So biomarker testing, so you'll hear a lot about this, especially coming up in new targeted therapy. What we're looking for is these little parts of the proteins or the receptors on your specific cancer that they can target as weaknesses for the cancer and start to get the treatment based on that. And what they're aiming to do is to either stop how the cancer will grow and thrive by cutting off its ability to grow its own blood supply and get nutrients, or we can stop how it spreads, or even get your own immune system to start helping fighting. And it's geared specifically to it, because not every cancer is going to have all the different markers. But if you have a specific marker that's targetable, they'll go after the weakness. And the good thing, there's about 39 new treatments available nowadays that they can target cancers in different ways. And sometimes if you combine them, they work better. But the targeted therapies, they have better survival rates. But here's the big thing. They have less side effects than the radiation and chemotherapy. So if somebody is a candidate to get biomarker testing, they might have an easier course of the treatment with a better survival rate. The problem is that blacks are less likely to even get tested to see what's available for them. 28 versus 40%. And that's the questions that the navigator is going to help you get answered is, am I a candidate for biomarker testing and targeted therapy? And those will actually improve the chances that we can do from our healthcare side. What about from your side, the patient side? How do you improve your own chances? Biggest thing right there, quit smoking. Because even though you may have the diagnosis of cancer, if you quit smoking, your likelihood of dying cancer decreases by 26%. And if it's early stage, it's 36%. So just by stopping smoking, it helps, because sometimes the smoking, the chemicals in the smoke may make the chemotherapy work less. Okay, so that's a big thing. It's help. I'm gonna, not spend. I can go on about vaping a whole lot. I like this, but vaping is not an alternative. Quit smoking. It actually, there's a 56% risk of developing lung cancer is increased. It's the same chemicals in tobacco smoke are going to lungs, so it still causes its own tumors and cancers develop. Right. The other thing that we can do that's extremely important is get into clinical trials. If you have a clinical trial jump into it. I know there's been some stigmata, and we can talk about clinical trials a little bit later in some question and answer, but there's been a lot of government oversight to make sure that things in the past don't happen again. But with clinical trials, you're often getting new therapies. We get a better understanding of African Americans and how they respond to treatment and the side effects in some of the treatments. Because if we look at all the oncology, the cancer clinical trials, 83% are not African American. Right? It means we're underrepresented in those studies, and if we're underrepresented, we don't know if the treatments work better for us or worse, or what the side effects are. And here's the other thing. If you don't have a lot of funding, if you get in a clinical trial, sometimes the medications and the treatments are free. So it could extend your life. So reasons to be hopeful. We now seeing with a lot of the changes that we're doing that the survival rates are starting to improve with lung cancer, that there's target therapies which are game changers that improve less side effects but better outcomes, and that we can attack some of these disparities with expanding screening, with navigators, and just with patient education. Health literacy helps us eliminate some of the healthcare disparities. And thank you for the time.
Thank you very much, Dr. Flano. Some very interesting points. I think the most telling thing, though, and we'll get to questions, I promise you. Yeah, so I apologize, but we'll have questions. That's all right. No. We'd rather have you ask a question. So please, write down things that you think you might want to ask us, and at the end of everyone's talking, we'll have a chance to ask questions then. Our next speaker is Dr. Melissa DiCarlo. Dr. DiCarlo is a clinical research project manager in the Department of Medical Oncology at the Thomas Jefferson University in the Division of Population Science, and her area of interest is in lung and colon cancer prevention and screening. Well, at least you got halfway right when you got the colon stuff going on. Colorectal surgeon here, so that's why it's important. Dr. DiCarlo is an associate director in the clinical translational research track of the Scholarly Inquiry Program in the Medical College and is an adjunct teaching assistant professor at Jefferson College of Population Health. Today she'll speak to us about the scan that could save your life, the importance of lung cancer screening. Dr. DiCarlo, thank you.
Thank you very much. So I think there was a little bit of overlap, so I'm going to try to skip right to the scan stuff. That's okay? Hold the microphone. This is one of my issues, making sure I'm loud enough. Can you hear me? All right, it's great to be here today. Thank you very much. So we talked a little bit about this already. Lung cancer is the #1 cause of death. Only 5 to 10 people out of 100 who are eligible get screened for lung cancer. And the complication with that is that lung cancer screening eligibility is hard to know. It's not just like breast cancer screening. You're a certain age, you get a mammogram. Colorectal cancer screening. You're a certain age, you get a colonoscopy, right? Lung cancer screening, the eligibility criteria are more complicated. So I'll try to focus on that. All right. So we all know our lungs are really important. The police chief was talking about how we're inhaling and exhaling things every day. This is where our exposures are coming from. So things that we can do are limit our risk, and so that's limiting your exposure, whether it's stopping smoking or wearing a mask when there's a forest fire warning, right? How we can limit our exposures, and also if you're eligible to be screened, because if you catch cancer early, it's earlier to treat and more likely to be cured. Okay. All right, so we heard a little bit about this already, right? You want to avoid toxic chemicals. Get your house tested for radon. It's not a complicated test. You can get a radon test at Home Depot. You may have seen those commercials with the babies in the little green socks. That's what I think of when I think of the radon testing. But if that's a concern that you have, you put it in the basement and it tests your house for radon. And then, of course, quitting smoking. And we'll talk a little bit about that, okay? So the biggest risk factor for lung cancer is smoking, also secondhand smoke. It's the chemicals that are introduced into your lungs that are causing the problems, all right? So now we have lung cancer screening, and I know that we asked this question before. Not a lot of people even know there's lung cancer screening, right? Breast cancer we know, colon cancer we know, but lung cancer screening is relatively new. And so just like all of those other screening tests, it catches cancer early. when it's easier to treat. All right. So there are some common misconceptions when you think about lung cancer screening. You know, maybe you're older and you just want to keep living. You're not really concerned about screening. My colleagues did some focus groups, some interviews, and these were the things that commonly came up when we asked folks what they thought about lung cancer screening. But getting screened can help you live longer. So even if you're at the edge of the screening eligibility, this is something that could help you. I didn't even know that lung cancer screening, there was lung cancer screening. I've never heard of it. So it's relatively new, and that's why lung cancer screening rates remain really low, because it's hard for physicians to make sure you're eligible, to tack it on to that visit that you already have all of your questions for, to start talking about your smoking history and making sure you're eligible. It's an extra thing, but if you think you're eligible, you can bring it up with your physician, then you can have that conversation to see if you fit that criteria. All right. A lot of people just think, if I'm going to get cancer, I'm going to get cancer. It just seems like there's nothing that can treat it. That's what my fate is. But there's a lot of things that have changed, and there's a lot of progress that's been made. My grandmother died in 1989 of lung cancer, and the things that we have learned and the progress that we have made is immeasurable. Especially when we can screen and catch it early instead of waiting for those symptoms and all of a sudden knowing there's a problem, right? That's a huge part of the change. All right? So medical care has greatly improved. So what is lung cancer screening? Lung cancer screening is not just a test. It's basically 3 parts. The first thing you're going to do is figure out whether or not you're eligible for screening. So to be eligible for screening, you have to be between 50 and 80 years old. Yes? Okay. I was ready. You have to be between 50 and 80 years old. So you have that age criteria just like everything else. You also have to be either a current or former smoker. And this is cigarette smoking only. So I know we just talked a lot about cigars and small cigars. The eligibility criteria for the insurance coverage of lung cancer screening is going to be cigarette smoking only, which makes it tough. So you have to be a current or former smoker, but if you've quit more than 15 years ago, you're no longer eligible for it to be covered, which does, however, speak to the fact that if you quit smoking within 15 years, that really changes your risk, right? And you have to have that 20-year PAC history of smoking, okay? And I'll talk more about PAC years in just a minute. So first you have to figure out whether or not you're eligible. Then you have the screening test, which is the scan. Or then you have to do shared decision making. So for Medicaid, Medicare coverage of lung cancer screening, you have to have some recorded shared decision making with your primary care provider. And I think I'm going a little far because that's going to be on my next slide. And then finally, you'll get the scan. All right, so how do we calculate PAC years? So it's the number of packs you smoke a day per years, and that equals your PAC years, right? So if you smoke 2 packs a day for 10 years, then you hit that 20-year smoking requirement, right? If you smoke 1 pack a day for 10 years, you're under the eligibility criteria. All right, so 2 packs a day, 10 years equals 20 PAC years. Now, smoking history varies, right? Maybe you smoked a lot 1 year and a less another year. This can be an estimate. If you, for instance, call the Jefferson Lung Cancer Screening Program, there is a nurse navigator there that will go through that in great detail with you to make sure she can capture all of those PAC years to add them up. If you do this eligibility criteria in your doctor's office with your primary care physician, it's probably going to be more of an estimate just because of time. But that's okay. No matter how you're adding them up, it's going to be 20 years for you to be eligible for screening. All right? Once you're determined to be eligible, there has to be some sort of shared decision making. This is something that I'm partial to because all of the work that we do is in shared decision making, so we work really hard to make sure that everybody has all of the information that they know when they're making a decision. You may have a discussion with your doctor. The idea here is you're just talking about the benefits and risks of screening. There are some risks to screening, though I wouldn't say they outweigh the benefits of getting cancer tested early. So if you're having a shared decision-making session with one of my research coordinators, it's going to be an even-keeled discussion so that you can make that decision on your own, okay? So why do we do shared decision making? There's a low dose CT scan. That's what you're working towards. So there is some radiation involved in that scan, but it's less radiation than going through airport security, similar to a dental X-ray, right? So it's low dose radiation. There's also risk of needing a biopsy and not detecting cancer, which is not a bad thing, right? But you may have to go through additional testing in order to determine whether or not, if a nodule was found, whether or not that was cancer, okay? So there's a few risks. You talk about that with your doctor, what the scan entails. The scan does not require any preparation. It's not like a colonoscopy where you're down for a few days. You go in, you have the scan, and then you're done, okay? But so once you have that shared decision-making test, then you go in for the scan. The low-dose CT, or the LDCT, is a CAT scan. It looks like a donut, right? It's not an MRI. You're not going in the tube. It's open, which I know is often a concern. So what it does is it takes you in, and it takes pictures of like the slices of your lungs to look for those nodules. It's a quick test once you're in there, and you don't need any preparation. Okay. And then after your scan, that's when you'll figure out your results. So we just heard all about the details of all of those results. But if you break it down, if 100 people have a low-dose CT scan, about 14 out of 100 of them will have a positive result. So that doesn't necessarily mean it's cancer, but there's some abnormal finding that will need follow-up. And that may include additional testing or a biopsy to get tissue samples. 86 out of 100 of those folks may have just a normal result. And your follow-up screening will depend on your result. So standard screening, this is an annual screening, right? You have a colonoscopy, sometimes it's good, 5 to 10 years, depending on the findings. If you have a normal low-dose CT, it's an annual screen. If they found nodules, depending on the size of the nodules or what those results were, the frequency of the low-dose CT recommendation will change. Okay? But it's hard. Not everybody's going to qualify for lung cancer screening. It's a very specific criteria. So things that you can do and think about to make sure that you're paying attention are what the signs and symptoms are that you want to bring to your doctor, right? Do you have a cough that persists or produces blood? Are we wheezing, chest pain, fatigue, right? Any symptoms like this, you can take to your doctor, and if your doctor is concerned, they can order a low-dose CT or a CT as diagnostic, and that's different. You don't have to worry about qualifying for the eligibility criteria, right? So if there's something that is not right that you are concerned about and you bring that to your doctor, they could order a CT without the eligibility criteria, and that would be considered something different, okay? Anytime you're worried, talk to your doctor, get screened if you can. The earlier, the better, and I think that's probably the message that you're gonna hear over and over, right? You find it earlier, it's easier to treat, and it's easier to potentially cure. All right? So you may not be eligible, but you can also do things to prevent, and that includes quitting smoking. If you smoke, it's okay that you smoke. There's many reasons why people smoke, right? It's just the thing to do. We didn't know that it was unhealthy at first, right? But even if you've been smoking your whole life, quitting now can make a big difference, okay? I unfortunately have to leave, but I will leave some further information for you about the tobacco cessation program at Jefferson. There's also a number of resources here that you can reach out to if you are trying to quit smoking. I'm realizing that you can't click on the links, but a simple search would probably send you right where you need. And then I'll have some flyers that I'll leave for the Jefferson program. You don't have to be a Jefferson patient to call the smoking cessation program. And those folks work in my office, so that's why that's the information I have. All right. If you're interested in lung cancer screening resources, Jefferson has a centralized lung cancer screening program, so you don't need a referral to call there. You can call the program, talk with the nurse navigator, and they will first walk you through your screening eligibility. So you can call and say, I think I might be eligible, and they'll ask you those questions so that you can figure it out. They'll also ask you a few additional questions about exposures for other things, just in case, but they can help you to figure that out if you think you may be eligible for lung cancer screening. There's also a couple of websites here, where you can go in and you can put in your information, and it helps you to calculate those pack years. So if you are thinking about it, but it's a little complicated, you can put in numbers. You can add multiple events. So like if you smoked 2 packs a day for 1 year and 1 pack a day for 5 years, right? You can put in those levels, and it can help you to calculate your smoking history. And there's also some information about just the risks and benefits, so that you know what you're going into. And there's some infographics in the materials that I'll leave for that as well, if that's something that you need. And then just some extra information if you're thinking about the radon. But you can get radon tests at Home Depot. I Googled it while he was talking because I was curious. Okay. And I'm realizing now that I failed to put my information on here. So just again, I'm Melissa DiCarlo. If you have questions about screening, I'm happy to answer any questions. I unfortunately do have to leave, but I think Shanika would be happy to share my information with you. Okay. Thank you. Thank you.
Good luck with the game.
Thank you.
Thank you very much, Dr. DiCarlo. I think 2 major take-home points there. If you're thinking about or you have a question about getting screened, please talk to your primary care provider and get it. And also, if you have a question, oops, sorry. If anything's wrong with it, we'll blame Dr. Flano. And for those of you, and if you have not had any radon testing, please, by all means, do get your house tested for radon. Our next speaker is Ms. Kathleen Gamblin. Ms. Gamblin has a long and storied career as a nurse navigator. This includes co-founding the Georgia Oncology Nurse Navigator Group and also being recognized by the Atlanta Journal-Constitution newspaper for excellence in oncology nursing. She has also authored 2 books on oncology nurse navigation. She is currently the Director of Navigation for Fox Chase Cancer Center. Ms. Gamblin will now speak to us about the Lung Cancer Navigation Program, comprehensive support for your nurse navigator. Ms. Gamblin. Is that correct?
Yes. Make sure I get this right. Okay. Okay. Let's see. I am so excited to be here today. I'm the Director of Navigation, so I don't get out of my office as often as I love, and patient care and being involved in the community is one of my favorite parts of my job all through these years. So none of my navigators could come today, so I was like, I'll do it. So very excited to be here with you today. So I want to start out by just a really brief history. So patient navigation has not been around all that long. It's not been recognized as kind of a nursing function or even a layperson function until around 1990. So Dr. Harold Freeman was a surgeon in Harlem. And as he started his practice there, what he found was that he wasn't able to operate on as many women as he wanted because women coming in were found to have late-stage breast cancer. They weren't coming in early enough to have surgery. They were coming in and dying in the ICU. And so at the same time, he was president of the American Cancer Society. And so they held these hearings, and it was hearings on cancer. And he took the findings from those hearings and also what he was seeing in his practice, and he decided to implement a project and see what would happen. And so what he did was he hired women from the community, trained them, and asked them to go out and encourage women to have breast screening, which also at that time wasn't as common, and then to kind of walk through them with it. And so the combination of them offering more free screenings, along with these patient navigators who weren't nurses at the time, they were just women from the community, resulted in, previous to that time, 39% of women lived till the 5-year mark. At the conclusion of the project, 70% of women were living at the 5-year mark. So from those very humble beginnings, that is where patient navigation started. It has expanded in all areas. It has moved far beyond breast. And I am honored to call him a friend and just did such incredible work. So we owe everything in navigation to him. So on to us. So this is what I picture a patient looking like. They're standing in front of this huge maze They've been told they have lung cancer. They've been told they have cancer, and they don't know where they're going next. You know, for me, in my mind, I know what the steps are. I know what you're going to do next. But in a patient's mind, a family's mind, it's overwhelming. And so the navigator can actually help make that a little less overwhelming for you. So what is patient navigation? I like this definition the best. It's a proactive, intentional process of collaborating with a person and his or her family to provide guidance as they negotiate the maze of treatment, services, and potential barriers throughout the cancer journey. So one, it's a proactive process. We want to reach out to patients. We want to work with them. It's not, oh, call me if you have a problem. It's, what can I do to help you? What are you struggling with today? It's an intentional process. What we want to do is work with each patient as an individual. Each patient, each family, there are many different situations. We don't want to cookie cutter and say, this is what we do for every single patient, because every single patient looks differently. We're there to provide guidance. We're not going to tell you what to do. We're there to help say, this is what your doctor's told you. This is what would be best for you in their opinion, but we're there to provide that guidance, not to kind of force you into complying. And then we help with potential barriers throughout the cancer journey. Has anyone here heard of social determinants of health? Have you heard that word used? You'll hear it now and then. Social determinants of health are those non-medical factors that can impact your health. So if you live in an area where you don't have access to fresh vegetables and fresh food, that can impact your health. If you live in an area where there's not accessible transportation, you can't get a bus, you can't get a ride to your doctor, that's going to impact your health. So those are something that we assess for, but we also assess for barriers to care. And barriers to care, we'll talk about in a little bit what those could look like. So here are some of the barriers to care. Practical. So when we think about practical, we think about, do you have transportation to get to your appointment? Do you have insurance? Do you have enough food in the house? You know, what are you struggling with on a practical level? Can you pay your heating bill? Are you choosing this month to pay for your medications or to eat? So your navigator helps tack into those things. Social. What kind of community do you have? Do you live alone? And even if you live alone, maybe you have a great faith community and you can rely on them. Maybe you have a social club in your neighborhood. So we kind of ask those social questions to see what kind of support you have around you. Psychological, what are you already dealing with? You know, just because you get cancer doesn't mean that you didn't have a prior diagnosis of maybe depression or some other mental health illness. And so now we need to worry about you a little bit more. We want to make sure that if you've already been struggling, that we're going to offer more support to you. Emotional, which is different than psychological. Emotional is, what's the impact of this diagnosis on you? You know, are you crying all the time? Can you not get out of bed now? Are you feeling completely overwhelmed? I have patients that get diagnosed and they just can't take that next step because it's so scary. Even though they know that treatment will help them, even though they know they need to do this, it's overwhelming to them. Physical, are there physical concerns you're already dealing with? Do you have high blood pressure? You know, do you have kidney disease? Is there something else? Not that we can't treat you with those things, we can, but we need to know about them. So we do that assessment. Spiritual, and when we say spiritual, we're looking at, are you feeling hopeless? You know, do you not see a reason to go on? We can connect you to resources. Are you connected to your local faith community if that's what you want to be? We can help with that. And then informational. I think it's at the bottom, but it's one of the most important things we do. It is all the information that you need. You know, how do I get my diagnostic testing? Can you tell me where I park when I come for my appointments? Is there a bus line nearby? You know, all of those things that go into your diagnosis. Do you have more information about what I've been diagnosed with? What can we provide you to help you? So we want to make sure that we give you all the information that you have. So we can provide information and education. So some of that looks like, I said, where do I go for my appointment? How many of you have gone to any facility, in the city, and you're looking at a big building, you have no idea where to go, and despite them thinking they have put great signs up, you're still wandering around trying to figure out where to go. We want to eliminate that for you. They said, I need a biopsy. What is that? I think, as we discussed before, a biopsy may not be in the operating room as a surgical procedure. We may be able to do that in radiology. So when they're telling you you need a biopsy, what exactly is that? What's the difference between small cell lung cancer and non-small cell lung cancer? I need help at home. Is there anyone that can help me? What services are available to me? This is a big one for us. I missed so much information at my appointment. What do I do now? My dad was diagnosed with cancer in 2007, and when the doctor called me to tell me, he lived in Pennsylvania at that time, and I was living in Georgia. I can tell you that the man said cancer to me, and I don't remember anything after that. Just completely blanked out, and most people find that. You get in that office, they talk, you're listening, but you go to leave and you're like, I have no idea what they said. Your navigator can help with that. They can help recap that conversation. They talk to me about clinical trials, but I don't want them experimenting on me. I think we've alluded to this a couple times. We have that information. We can talk to you about how we protect you and how we make sure that everything you do is with your consent and that you know all about it. So navigators have a lot of information. A nurse navigator can provide access to support and resources. So within the facility, in any facility here in Philadelphia, there's going to be resources available. There's physical therapy. Maybe you need nutrition support to talk to a dietitian. And those are all available. And then there are all these great organizations out there that offer support. Cancer support community, there is one here in the greater Philadelphia area. If you work, Cancer and Careers really helps support you by telling you what your rights are under the law, what you have to disclose to your employer, what you don't have to disclose. Triage Cancer, great organization, go-to for lung cancer. I work a lot with Longevity. They offer great support groups online and offer amazing information. Patients from all over the country come, and it is very incredible because support groups in facilities often struggle. We have trouble getting people to come out, traffic, parking, time away from home. So many people prefer to be at home on their computer where they can see people and they can chit-chat, but they can do it from the comfort of their living room. And the American Cancer Society, so dealing with transportation and other resources. There are things out there, there are grants, there are monies, there are smaller organizations in all cities where someone may have had a relative that passed, they hold a golf tournament, they raise $10,000, and they want to give that back to cancer patients. We want you to be able to access that, and we want to be able to help you in any way you can. So we can provide that information to you. We can help with what questions to ask the provider. So if you're going to an appointment and you're like, I just don't even know what I should be asking them, we can help you with those questions. 9 times out of 10, I'm going to tell you the providers are fantastic. They are going to go through these. You're going to get an answer to all these questions you won't even need to ask. But it's good to know, hey, this is one you didn't cover. Can you tell me more about this? So we can help you prepare that. I think the biggest thing that people tell me about nurse navigators is they answer the phone. We are one of the few services within a hospital where you are not usually going to go to a number to push a button, to push another button, to push a button to reach voicemail. Every nurse navigator that I know across the country, we all have direct lines for our patients to get a hold of us. So we can provide, we can't change your appointments and we can't do scheduling, but we can be that point of contact. If you don't know who to call, you call us and we'll help you figure it out. We're kind of the problem solvers. I kind of see us as standing in the center of a circle with your care team all around you and the nurse navigator is standing right beside you. Like, what is it that you need? Let me help you get to whatever that is. We can help you communicate with your healthcare team. A couple years ago, I had a patient and they wanted to take her to the OR. for lung cancer, and they made a plan in the tumor board, and they were like, we've got a spot, we're going to take her next Tuesday. And I was like, that's great, except she has 2 great-grandsons at home that she's the primary caretaker for. So we're not going to be able to take her Tuesday because we're going to have to make sure that she feels like her grandsons are safe. And we were able to do that, and she was able to move on with her surgery. So we can help you communicate if you feel like you're having problems or there's something that you just feel awkward about talking to the physicians about. We can advocate for you, and we do. Like, we will fight with physicians if we don't think something's quite right, or we feel like something needs to be moved up, or, we're trying to help you. We're your advocate. We can ensure you're seeing the correct physician, and I put Fox Chase behind that because that's what my navigators primarily do. So when you call and get a new patient appointment, you go to a list from my navigators, and when they call you, they walk back through that list with you to make sure that when you come in, you're seeing the correct physician at the correct time, that we've not set you up accidentally with somebody over in this specialty and you need to be over here. We can listen when you're afraid, when you're just overwhelmed, you need somebody to talk to, or when your family needs someone to talk to. Because we don't provide direct medical information, so we're not giving test results, we're not doing things like that, I can talk to a family member who calls and says, my mom has lung cancer and I'm scared. And we can also listen to you. I had a young lady whose brother was diagnosed with melanoma. She called me 3 times a week, at least, for 6 months after his diagnosis. She just needed someone to talk to for a minute. And the phone calls didn't last long. It was 5-10 minutes, got her going. We can talk to your family when they're afraid. And I said that. I put questions here, but I recognize don't ask questions because we're going to wait till the end. So I'm going to stay after. I have my information. I'd love to talk more to you if you have any questions or anything like that. Thank you.
Thank you, Ms. Jones. Not a problem, not an issue, I assure you. As you see, that not only is getting information from the patients very important, but also that group of people, the nurse navigators. And I think one of the important things about the nurse navigator is the fact that they're nurses. Nurses have a different attitude than physicians. Being a surgeon, I can tell you, it's totally different than what we have, but it is a very important thing. And so, very important. If you have any questions, that's one of the first groups to reach out to. Our next speaker is Mr. Brian Green. Mr. Green is the founder and chief AI officer of Health Visions AI, stands for Artificial Intelligence, and an artificial intelligence governance architect and advisory firm. Forgive me, sir. He's also the founder and CEO of the development arm of Envision Health AI. He is now building Health Rounds AI, a program designed to teach clinicians how to use AI responsibly and to enhance how they communicate with patients. I'm interested to hear how we can improve. Anything we can do to improve our communication, as we've heard, is one of the big issues sometimes when talking to cancer patients. Mr. Green is also an adjunct faculty member at Thomas Jefferson University in the Health AI program. Mr. Green's topic for today is Let's Explore the Revolution of AI Tools in Lung Cancer Care, Early Detection, More Accurate Diagnosis, and Personalized Treatment. Mr. Green, thank you very much, sir.
So I talk with my hands a lot, and this is going to be challenging because I'm going to end up waving it. I always forget that I have a microphone in my hand. Thank you, and welcome everyone here. I'm so glad to be here with you today to talk about the important topic of lung cancer and any questions you might have about how AI is used now in lung cancer screening and care. How many here have used ChatGPT or Claude or Gemini for any reason? Okay, so you're somewhat familiar with the concept of AI and what it might be useful for or not. I'm going to stop for a second, though. One thing I did in my decades working in healthcare is in 2017, I was part of a team that launched an online community for people living with lung cancer called lungcancer.net. It still exists. It's not the company I work for anymore. But it was designed as a place for people that are living with lung cancer, meeting their needs where they're at. So information, support, that sort of thing, but fully online. One thing we did was a survey back in 2019. This is a link to that paper. But we found that of all the people we surveyed, and it was 1,000 or so people, 73% of people surveyed with lung cancer reported what we called scanxiety, right? And scanxiety is a term that means, I have to go get a scan tomorrow, and I'm really anxious and nervous about it because I'm afraid it might be bad news, right? And we heard this already. This is a real thing. It's very common, as you see, people living with lung cancer. And, it doesn't end, as people know, and we heard again, you could have what's called no evidence of disease, right? You've gone through some course of treatment, surgery. There's no evidence of disease. You don't have cancer, but you've got to do that annual. You're still going to have scanxiety, most likely. That's normal, again. And, this is the real challenge, is that people with scanxiety reported that it affected everything about how they dealt with their family, their caregivers, everything, and they had a lower reported quality of life. So this is something that's really important and kind of started my journey in a number of ways of thinking about how we can improve care, which I've always done. But when AI began to be a thing, coming back to this notion as how we keep all of our care patient-centric, working within what patients need, and understanding that for lung cancer specifically, what we're often dealing with is the less common forms of lung cancer. So non-small cell lung cancer, you've heard, is the most common. In your folder, there's this awesome little card from Amgen, pointed out, because what it does is it actually tells you the type of biomarkers or the mutations that happen. These are often rarer forms of lung cancer, and make sure that you get tested for those and that you ask your doctor about them. This is actually why I got interested in AI, is because of rare diseases. And one of the specific subtypes of lung cancer, ROS1 mutation, where there's only a couple thousand people diagnosed with this type a year, and feeling like there wasn't as much information for them. So what is AI? In plain language, it's not a robot. It's really a tool, right? So think of like spell check and what that is for you. It helps in lots of different ways. So AI learns patterns, and for lung cancer specifically, it's different than like a ChatGPT language-based type model. This is primarily visual AI. So it's learning off of things like CT scans, X-rays. In fact, radiology was one of the first parts of medicine to actually use AI. So there's a longer history of this within radiology and oncology specifically. It provides an extra set of eyes, right? So you already heard the importance of a second opinion or a third opinion, and that's what AI can do, is not just provide a second or third opinion, but it actually allows your doctor to have another opinion that helps guide them through the next steps and how to talk to you about those next steps perhaps better. Also, finally, it can help doctors spot the small things, these nodules, right, and watch them as they change over time. Again, it uses what's called visual, it uses visual patterns and learning to advance what we're doing. So you already heard about the importance of low-dose CT, and AI can specifically help with this type because it's low dose, so it means it's also harder to detect or isolate amongst images. One single scan could be 300 images, right? And so AI can really help sort through those things. AI eyes essentially don't get tired at image number 287, right? So someone right now, individuals, a radiologist has to look at these. They then consult with the oncologist, and they're all looking at these images. AI can help with that. So again, it gives a second or third set of eyes. It flags things that are easy to miss, watches for changes, and provides things where there's less clarity in an image. Let's put it that way. And then besides screening, actual care and treatment can be significantly impacted by AI in a positive way. So in the lab, it helps the pathologist sort out the type of lung cancer. Now, some of that has to be through genetic testing, right, which AI cannot do the genetic part of it, but it can it can have the radiologist or oncologist think about the potential need for these genetic tests. In the details, the AI research tools can hint at these specific mutations, differences in the way it looks. We have visual AI, as I said. We don't have what's called spatial AI yet. There's research on that that will actually help with this even more. And then in the planning stages, meaning the physicians that are planning your treatment, your surgery or whatever, for radiation, AI can help isolate the organ or the tumors in the lung, and what we call contouring, right? So that's isolating for radiation so that the tumor that might be at the edge of a lung, so that's isolated so you're not extending the radiation to something that might harm another organ. So tying this back to scanxiety, my belief is anything that helps patients feel better around their treatment, feel like they're being listened to, that they're included in the shared decision-making that you heard about earlier that's so important, is good, right? And if AI can do that for people, then that's a good thing. But not all AI is created equally, and there's also the potential for harm or misuse if it's not used correctly within a healthcare setting. So, just like you've heard from other speakers, as a patient, the best thing is to always advocate for yourself and know what questions to ask. When there's AI in the picture, same thing. Ask your healthcare team, do you use AI to read scans here? And then ask them the follow-up question, well, how does that help? Does it actually help me? How's it going to help in my care, right? You don't have to consent to the use of AI. You can say no, right? And if AI suggests more tests, now suggesting it to the physician, it doesn't just do it on its own, right? It's like it's a team that it might make a suggestion to. But if they say, okay, AI has suggested these other tests, ask, how will that change my care, right? Do you want just test after test after test after test if it's not going to help your care? The answer is that it probably will help your care, but you need to ask, and it's helpful to know. Waiting is hard on your family and you, right? And you want to talk about that. That's great reason to have a nurse navigator, because they can help you with that. They can find resources for you. If you want to talk to someone else on the care team more frequently, they can help make that happen as well. Caregivers are a big part of the picture. Family members are a big part of the picture. And if you want to include them in your care, please feel free to ask for that, because that's part of what helps people. So I'm available to answer all kinds of questions later about AI. I didn't want this to be just focused on AI, just focusing on how AI can be helpful. There's certainly things to be concerned about with AI. But the goal is not to have more machines involved in care. We already have a lot of technology, and technology can be intimidating to care teams as well, not just to patients. Technology can also feel isolating if we don't use it well. But the goal with AI is really to have more humane care. If you've used AI, you might know and notice that AI can be very good at mirroring human empathy, right? It can mirror it back to you. It can actually sound very empathetic, but that's not the same as real empathy. And it's not the same as getting empathy from your care team, which is where you need it, or your family members, which is where you need it. So AI is here to support and not replace your care team. It's a good tool that gives clinicians more time to spend with the patient. It frees up nurse navigator resources so that they can spend more time with you. That's what it's for, is really to help the humans be more involved and embrace you in care better. So therefore, your experience, including scanxiety, at least for people like me that are working on developing AI within healthcare systems, things like that matter. We want to make sure that we're always doing something in a way that actually incorporates the patient experience and improves upon that and improves upon the quality of care that you receive. Thank you.
Thank you very much. Appreciate that. It is interesting looking at the number of tools that are available to clinicians and for those in healthcare now. And AI is clearly going to be one of those that's with us, but finding the right role for it is going to be hard. Those of you who have questions, please, again, I want to encourage you to write them down. And for those of you who are online, if you have a question, please submit it, and we'll try to get to that also. Our next speaker is Dr. Khadija Mitchell. Dr. Mitchell earned a graduate certificate in health disparities and health inequality from Johns Hopkins Bloomberg School of Public Health and her PhD in human genetics and molecular biology from the Johns Hopkins University School of Medicine. She is recognized for her expertise and was honored with the Peter C.S. Daubermont, MD, Endowed Scholar of Health and Life Sciences and the NIH Fellows Award for Research Excellence. Currently, Dr. Mitchell is an assistant professor in the Cancer Prevention and Control Program at the Fox Chase Cancer Center, Temple Health, and Department of Epidemiology and Biostatistics at the Temple University Barnett College of Public Health here in Philadelphia. Today, Dr. Mitchell will speak to us about the source of stigma in lung cancer care, misconceptions of disease responsibility, impact on care, and outcome. Dr. Mitchell, thank you very much.
Good morning. All right, come on, you can do better. Good morning. All right, that's what I like to hear. So, my name is Khadija, and today I'm going to talk to you a little bit about the work I do. And I want to point out something. Here it says I'm a professor of cancer prevention and control. And what does that really mean? So, I'm a daughter of Pennsylvania. I was born and raised in Pittsburgh. Go Steelers, we're not rivals. But then I moved to the Lehigh Valley, right? I worked there, and then I came here to Philadelphia. So I've lived on the western side of the state, more on the central side, and then here on the eastern side. And some things that are similar in communities that I grew up in. So I'm from a little town, my family outside of Pittsburgh called Braddock, Pennsylvania, and there's a steel mill there. And so I used to wonder why so many people in my neighborhood got cancer. And so when I would ask people, some people say, well, it's the steel mills, it's the air, it's the water, it's the land. And that really got me thinking there are many different reasons why people would get cancer. So the part where it says cancer prevention, I think about why people get lung cancer, and I research that. I think of the different factors, and particularly I study Black populations. And most likely, because I'm a health disparities researcher, because sometimes I feel like those communities get less attention in the research space, right, to help us come up with new ways to not get cancer. But on the flip side, there's the control part, right? So the control part is, by training, I'm a geneticist. So I know I'm not supposed to ask questions, but by show of hands, who knows what a geneticist does day to day? All right, a couple people. So, well, I'll just give you a little insight, so then you can think about it as the presentation goes on. So I basically take some of your blood or a piece of your tissue, so we heard from some survivors today, and I open it up. I just bust it right open. And then I look to see, do you have a gene that's working right or a gene that's working wrong? Very simple, right? But for me, I particularly look in Black populations because we talked a lot about targeted therapy, but the reality is we are not a part of the clinical trials that got us to some of those drugs, and sometimes our targets look different. It doesn't mean we don't have the same targets, but sometimes there's better treatments that we can pick. So that is what I study when I think about cancer prevention and control, and how that shapes our view of risk, because lung cancer actually is more complicated than we think. So this question here, what's the first question that people ask if you found out that somebody has lung cancer? Do you smoke? Yep, there we go. You guys would have got an A on that exam. And so the reason that's the first question, we don't think about it consciously, subconsciously, it's stigma, right? It's stigmatizing. We feel like, well, you know what? You must have done something to get that. Why did you smoke, right? And that I'm going to talk about has a huge impact from screening, prevention, screening, all the way to treatment. So what is stigma? Stigma is an undesirable stereotype which derives from an attribute, a characteristic, or behavior which is seen as different in society. And so we put some type of value judgment when we stigmatize someone, right? But I want you to walk away with understanding, and this is the key thing, that lung cancer is shaped by so many different factors. So yes, even though we know, we've seen this twice today at least, cigarette smoking increases your risk 20-fold, right? That cigarette smoking is a behavioral factor, so it's something that you can do about it, right? But I want you to think a little more broadly about cigarette smoking. So who knows that there, by show of hands, there are different types of cigarettes? All right. So we know there's brands, right? So if you had to think of the types of cigarette, how many of you know what a menthol cigarette is? All right, less of us, right? So a menthol cigarette, it's an additive, you know, makes it, people know cool, people know camel, all these different types of cigarettes, right? But a menthol cigarette actually is harder to quit. So when we say just stop smoking, it's not that easy. So I study how hard it is or how easy it is to stop smoking a menthol cigarette versus a traditional cigarette. And you may say, well, Khadija, why would you look at that? Because when we look at who smokes, if you are a Black American, 85% of Black Americans smoke a menthol cigarette, right? If you're a white American, it's 30%. Why is that so big, right? Targeting, big tobacco, right? So some of us, when we're talking about smoking cessation, we have to talk about how to tailor that to particular communities. So in Black community, it's menthol smoking. So how many of you know we tried to ban menthol cigarettes? All right, we tried to do it twice, right? It didn't work. Philly, you know, you should be very proud of Philadelphia because Philadelphia tried to do it before the country did. You know, there are some countries, Canada, Brazil, the European Union has banned menthol cigarettes. But here in the U.S., big tobacco keeps pushing. That is why it's very, very hard to quit smoking. So we need to think about that's more complicated than just smoking. Environmental factors, so we talked about radon, right? So I know everyone said you can go buy a radon kit. Actually today brought 100 radon kits, so if you want to get one, you can get over there. So radon, you can't see it, you can't smell it, you can't touch it, but radon causes lung cancer. It's the second leading cause. So we talk a lot about smoking cessation, but what happens when people stop, right? You still have other exposures. You don't want your cancer to come back, and particularly in Black people tend to live in environmental justice areas, we call it, and they have more exposures to things in the air, the land, and the water, like I mentioned before, but also in the house, right? So you have things in the house. So the test kits, which you can use, it can tell you how high your radon is. In Pennsylvania, we have 40% of the houses have high radon. That's almost half. That means 1 in 2, right? Now, within Philadelphia, the zip codes, there's variability in the zip codes. In the surrounding counties, there's also some variability. It could be high or low. So even though your neighbor may have low radon, you can have high radon. So you have to test. So that's important. And then biological factors. So we study, I told you we study menthol cigarette smoking. We look at radon exposure. So in fact, I'm an advisor for our state Department of Health. We have this an office called the Office of Health Equity. And so there, what I formed, it's a statewide alliance. And we have something called the Radon Health Equity Work Group. And what we do is look across the state, and particularly communities of color, to look at what that exposure looks like so we can lower the risk. And then finally, I'll talk about biological. So like I mentioned, the genes, so the purpose of all of this, if you can figure out what type of exposures cause biological change, then we can make new drugs, right? We can make new treatments that can be tailored for that. So it's like going into the store, right? You can pick, if you want to use Blue Magic, right? You can go to Shea Moisture, whatever you want to do and put in your hair, right? We want to do the same thing when it comes to lung cancer, that you can personalize your prevention and personalize your treatment. So the take-home message is lung cancer is a complex disease. Right. And so we have behavior, environmental, biological, but also where you work, and there are other risk factors. So we know that we had an air watch around here last week, right? And why do we have that? Because the wildfires, right? You had to stay indoors. So air pollution is also a risk factor for lung cancer, right? So we can't stop the air coming down from Canada, but there are things we can do. The behavior was like to not go outside, right? So that's an example of how complicated this can be. So when we think about stigma, we should be thinking past, oh, you smoked, you got that, you deserved it, right? So here we want to think that it's not a moral or failure of someone's values if they get lung cancer. Right. So stigma has two faces. So the first is internalized, so things that are inside me. So feelings, when I talk with communities in the research, they say they feel shame and guilt and regret and a lot of self-blame. And this is replicated by decades and decades of research and people all around the country, that these feelings come up in lung cancer patients around the country. And then when you think about perceived or enacted, so these are externalized stigma factors, so the things that are around me. So think about family, right? It's typically the first that we know. Think about friends, but then also thinking about your community members, as well as your providers, the actual interaction with the healthcare systems. So how many of you have ever felt that your healthcare provider has a stigmatized view of you? They viewed you differently. All right, okay. So sometimes even providers think, why did you smoke? We have resources. And so there are people who research that, and we think about what are the factors. So that can stem from family, friends, healthcare providers, and society. So the issue of how this impacts is when this blame, this stigma, becomes a barrier, right? So my colleagues today talked about everything from screening all the way to treatment. So I'll think of going from prevention. So stigma can interrupt care at every stage of what we call the cancer control continuum. That's from the beginning to the end. So prevention, a complex disease is reduced to smoking, like we just talked about, right? Lung cancer is more complicated than that. Screening, so fear of judgment can stop care before it starts, right? So even though somebody has a positive scan from a screen, it could be they don't want to talk about this, they don't want the family to know. We see a lot of these factors come up in the research. Diagnosis, so people may stop, help-seeking behavior can be delayed, symptoms may be dismissed or overlooked. Okay, so I'll tell you a personal story that happened in my family, specifically a diagnosis. So I had a cousin that was diagnosed with lung cancer. So when they went to the oncologist, what happened is it was my cousin's husband. And my cousin, she said, well, we're going to pray. She wanted to make him turmeric tea, and she wanted that to be a part of his treatment plan. So the provider said, well, that's foolish. That's not how you treat lung cancer. Don't come here and tell me about no diet, no Dr. Sebi, no alkaline diet, no pH 8, none of that. You're going to take this chemotherapy. Well, she got very offended, right? She said, well, prayer works for me. She was just trying to help her husband. So she decided to not seek care after that. So that delayed it. It didn't delay it, just stopped it. It stunted it, right? Her husband died 2 months later. Now, what could have happened is if they had a different experience, right? There are wonderful oncologists that would say, well, let's talk about how that may complement treatment symptoms, mitigating symptoms, right? After your treatment, how that can help. And actually, studies do show that individuals who have some faith system actually have inflammatory markers in parts of their brain that lights up that helps them with recovery, right? But instead of that type of conversation, that's why. So stigma is very important from the personal perspective, but also from a provider's perspective. And then treatment. So blame can weaken trust and communication, like I just mentioned in that vignette. And survivorship. So shame and isolation can harm well-being. And so the benefit, and what I love what Brian said, so it was a great pass of the baton, is empathy. That is our superpower. Studies show that when we have interventions at this level, go backwards, right? When we think about the internalized stigma, the inside, and the externalized stigma, the outside, studies show that empathy, accurate information, nurse navigation, like Kathleen said, and equitable care can actually interrupt stigma from prevention all the way to survivorship. So when I think about disparities, so like Dr. Tuckson said, I think about factors that cause people to get cancer, and then factors we can do to help people better treat the cancer, right? So I want people to have more birthdays. I like parties, right? So how do we do that? So we have to think about the people who currently or formerly smoked. So what do you think, for the most part, people think, well, stigma goes down if you stop smoking, right? It's like, well, at least you quit. People still have those same type of stigmatizing guilt. They still have greater blame, guilt, or self-stigma. And people who never smoke, so this is interesting. So at Fox Chase, we actually have a never smoker clinic. It's one of the few never smoker clinics on the East Coast. And I work with those patients and those populations, and we're trying to figure out, well, why is it that never smokers get lung cancer? And never smokers actually are on the rise as smoking has gone down. Right? And in fact, in women in particular, we see very high rates of never smokers and lung adenocarcinoma. So this group may be overlooked because others assume lung cancer is only a smoker's disease. And I want to say something. So we're talking about screening, and we talked about eligibility, but if you're a never smoker or you haven't smoked as much, you are not eligible for lung cancer screening, right? So this is where you have to really be an advocate when you talk with your doctor. You have to show them that you know it's more complicated, like I told you, right? You know these other risk factors, and they have to figure out how to make sure to monitor you, how to watch your care, all right? All right, and then at the bottom, thinking many people already facing unequal health care are going to experience compounding impacts of stigma. So on top of racism, we know African Americans report higher rates of stigmatization, sexism, women. So there are studies that show when a female patient goes to a physician and say, I have a certain pain on a scale, then the providers traditionally in these studies think that the female's pain is not as bad as they think, right? It's not as harmful or hurtful. But the studies show that sometimes it's actually higher than what they're reporting. So when we think about sexism, this can be compounded. Financial barriers and poor communication. So the key, like the example I mentioned from my family, the poor communication, right? So when you have better communication, you have great communication with your providers. So I love our survivor story said that. That actually leads to reduced stigma. So what can you do? So I mentioned empathy. We put that in clinical practice, right? We train providers how to be more empathetic and how that helps with reducing stigma, whether they're in training or practicing providers. But what about the rest of us? We talked about self-stigma, we talked about family, we talked about community. And the studies show, again, empathy, right? That words can hurt. Okay. Words can hurt. That's my cue to wrap it up. All right, so words can hurt. So did you smoke? They did it to themselves, and why didn't you quit, right? But we know that words can also help. So instead of saying that, maybe you can say, I'm sorry you're going through this. How can I support you? No one deserves cancer, and everyone deserves excellent care. And nicotine dependence is complex. I talked about the menthol smoking, right? What support would be helpful now? So I'll end this with 3 key takeaway messages. So no blame. I think this is not a value judgment getting lung cancer, right? Know your risk. There are many different reasons and factors why someone gets. And to take action. So here we talked about all those things, but like one of the factors we talked about, radon. You can't see radon, but you can test for it. So that's what the kits look like that are over in, I think, the fellowship hall. But similar with stigma, you can't see stigma, but you can still interrupt it. So no one deserves lung cancer, and everyone deserves compassion, information, and excellent care. Thank you.
Thank you very much. Thank you very much. That's right, because there is no stigmata. It's not a question of how you got disease. You got the disease. So let's deal with that. And I think that's very true. Again, I'm going to remind people, there's screening for heart and renal disease, and I strongly encourage you, if you have a chance to stop by, it's just outside the door there. Care access to the folks who provide that. Our final speaker, and he's got a plane to catch, is Dr. Sunil Corelius. Dr. Corelius earned his MD from the University of Rochester School of Medicine and Dentistry, and then completed his training at Temple University Hospital, and then he came down to where I'm from, down at Howard University. He is the president and CEO of Corelius Cardiology, where he is a practicing cardiologist and the founder and CEO of the Community Cardiovascular Initiative, a nonprofit group is working to reduce cardiovascular health disparities and expand heart health education in underserved communities across the Philadelphia area. More importantly, he's also the author of 2 books, Hypertension, Killing the Silent Killer, and Healing the Spartan, Breakthrough Plan to Heart Health. Today we'll be hearing about Know Your Lipid Numbers, metabolic key connections between lipids and lung cancers. Dr. Corelius, thank you, sir.
Thank you for the warm introduction. Wow. Good afternoon. Good afternoon, everyone. Do I need the mic? Yep. I need the mic. Okay. I'm been determined to keep the mic. I'll keep the mic. So I know, as mentioned, I do have a flight to catch, but it was important for me to be here and thank you all for being here and sticking with us as we went through this morning of many different presentations talking about lung cancer, and now we kind of see the connection between the lungs and the heart. And before I get started, let's do an exercise for me. Can you all stand up, please? If you cannot stand, just raise your hands. Just let the heart know that you're thinking about it. You know, you're giving all the information to the brain. We don't want the heart to be jealous. The heart has feelings too, you know. All right, let's go ahead and take a seat, please. So, feels good, eh? Feels better. I see some people still stretching back there. I'll let you get your heart happy. Yes. So let me start by saying two patients, right? Two patients diagnosed with lung cancer. Same type. They get the same treatments, chemotherapy. They have the same oncologist. One did well and survived and thrived, and the other one developed heart complications, heart attack, stroke, heart failure. And so we wonder why. And so that is the reason why I'm here today, to talk to you all, to try to understand why, because we are now discovering more and more that there's not much of a difference between heart health and cancer health. So as we're trying to fight cancer, the same mechanisms that exist that cause heart disease can also, there's an overlap, can cause some overlap with cancer. So as mentioned, I'm Dr. Koyelos. I'm the CEO of Koyelos Cardiology. My passion is really in helping you all, the community, understand how to really bridge the gap into the better health when it comes to your heart, and also when it comes to your overall health and well-being, including cancer prevention. And so as we are trying to navigate that, it is important that we understand how diseases progress, how cardiovascular disease develop, and how cancer develop, and what is the synergy there, what is the overlap. And we're going to talk about the metabolic key connections between lipids, hypertension, the whole concept of inflammation, and lung cancer care. So we do have a little bit of, looks like the slides kind of got a little bit, need some surgical intervention, but nonetheless, we have a surgeon. Oh, no, he's not scrubbing this morning. He's in suits. But so key differentiator, right? So we talk about these two patients. The key differentiators we need to think about is really about metabolic health. It's really about understanding the metabolic milieu. You have to understand that what are some of those things that lead to cancer? What are some of those things that leads to coronary disease or heart disease? And when we think about heart disease, we think about the risk factors. We think about the hypertension, diabetes, and most importantly, we think about what one of the leading causes is hyperlipidemia. The lipids, the hypertension, the diabetes, they all lead to inflammation. They lead to inflammation of the cardiovascular system. Essentially, what that means is they cause fire in your arteries. Inflammation, you can think of fire. It's really what happened is there is increased thickening of the lining of the inside of the artery that causes the blood to stick to the inside of the artery. And then once the blood sticks to the inside of the artery, then you have particles like your lipids. We talk about your lipids. When we talk about your lipids, we'll get into that a little bit. But the lipids, particles, get inside of the wall of the artery that cause the artery now to wall to start thickening, and that causes disturbance in the flow of blood to the artery. And that's what, when we talk about inflammation, that's what we're talking about. And when we're talking about heart disease, that's essentially what we're talking about. So it's a fire. The wall is not happy. The wall is angry. It's really swollen. Those are the kind of things that you can think about over and over. That's how you make that correlation. And so when we think about some of the processes in cancer, when it was mentioned earlier about radon exposure, about smoke exposure, that is the same process that's happening. Once the exposure, once the substances, the nicotine gets into the lung, the lining of the lungs, there's irritation, and the irritation is what is causing the inflammation, and the cascade continues on, just like it does in the arteries of the heart that causes the heart disease. So when we talk about, let's go into the lipids, right? So when we talk about lipids, we need to understand the total cholesterol does not tell the full story. We have to understand that there are breakdowns to the total cholesterol, to there are breakdowns of the lipid profile. And we need to understand there's the LDL, which is the bad cholesterol. That's the cholesterol that goes into the wall of the artery. That's the particle that penetrates the wall of the artery that causes that inflammation, that irritation we talked about. So you need to understand that. And HDL, which is the good cholesterol, that one is really the one that you want to have elevated. It's the good cholesterol. So in your profile, if you HDL, we want it to be as high as possible, and your LDL, you want it to be as low as possible, because they do the opposite when it comes to the inflammation that we talk about in the wall of the artery, right? And so much so, now we're talking about, there are two other numbers that you need to be aware of. There's one called ApoB. ApoB is the total particles in your body of cholesterol. So the higher that number, the higher your chances of having that inflammation, that irritation, that fire in your wall of the artery. So you want to keep that as low as possible, the ApoB. But lipoprotein A also is another one you need to be aware of. Lipoprotein A is more inherited, it's genetic. So now we are finding out there's a higher risk of cardiovascular disease when your lipoprotein A is elevated. So so you need to be aware of that, and you should all have your lipoprotein A checked. And I'm sure that's one of the tests that's being offered here for you to know. So you will know that number. So that'll give you the number. You know what is your chance of having inflammation or irritation in your arteries that can be happening. Because a lot of times that's why you probably will not know about that you have heart disease until something happens, because a lot of times these things are happening. The fire is happening in your artery, inside your artery. You don't know until it gets to that point where you start having complications like heart attacks and the strokes. So high blood pressure also is a big contributor to inflammation, to irritation inside your lining of your artery. So the pressure being high goes and start causing irritation in the wall of the inside of the artery, and that's what causes the breakdown. So you can imagine, so the hypertension helps the bad cholesterol, the LDL, get in. So together, if you have high blood pressure and you have high LDL cholesterol, then you have two contributors to having that fire in the wall of the artery. You can imagine, okay? So that you could be having something brewing in there that you don't know because you have the elevation of those two components. So that's why it's very important that you know your numbers, and we'll talk about that. We'll talk about the number for blood pressure should be less than 130 over systolic, less than 130 over less than 80. 130 over 80 should be your cutoff. If you're above that, you need to know how to get that down. Have a plan with your doctor to get that down, because the higher the pressure, the higher the stress on your inside the wall of your arteries, the more likely a fire is happening inside your wall, okay? All right, so who are the usual suspects, right? So we talked about just like for heart disease and stroke, there are overlaps, and that's why we talked about, okay, there's if the process, the same process that's happening inside of the wall of the artery that leads to the heart disease, the same process is happening when you're exposed to smoking, to inflammation, stress, and blood vessel injuries. Those processes are also the path to cancer. So that's why chronic inflammation is something that you want to be mindful of, and you talk to your doctor, and you have a plan necessary to be able to prevent the stress, to be able to prevent all those factors from leading you into the state where you are exposed to having the cancer or the heart disease. Okay, so what numbers should you know? What should you know? Okay, you should know your blood pressure, right? We talked about that. You should know your LDL, which is the bad guy, the bad cholesterol, right? You should know your You should know your HDL, which is the good cholesterol that's gonna fight for you against the LDL. And ApoB, we talk about the ApoB, the lipoprotein A. Your hemoglobin A1C is a marker of inflammation. That's your diabetes. If you have diabetes, you should know that as well. And so if you don't know those numbers, when you go to your doctor, those are the kind of things that you want to have a conversation about. And don't leave the office. You don't go to a doctor, you leave, and then somebody asks you, what was your blood pressure? You don't know, because those are your numbers. You go to the doctor, you should know your number. You don't walk away without knowing your numbers, right? So the doctor doesn't take the pressure for them, they take it for you. So you need to know, okay? So you need to know that's your number. Just like you go to the bank, you know what's on your bank account, right? the teller is gonna deposit the check. You say, "Can I have a balance, please?" All right. So protect your heart. You gotta protect your heart. So the way you protect your heart is by knowing your numbers, know your lipids, know your blood pressure, and those preventions, they do matter. Cancer care is no longer just about adding years to life. It's about adding healthy life to your years. So what that means is you got to be proactive. You have to be intentional. You have to do those things that will help you to prevent the inflammation, the fire, from happening in your arteries. Any questions? We're going to end it here. That's it. All right. So, what time is it?
I don't know. You got the big watch. Let's bring our speakers up here to have a seat. Let's get our speakers come up.
I have a few minutes. I'm going to take out for a few questions.
Have a seat. Have a seat. I'd like to bring our speakers up for a few more questions. And thank you very much. Come on. Speakers, come on up here. Sit down. Y'all got the man scared. He's afraid to sit down, man. Well, let's start things off while we're here. Thank you very much. Because I know you're going to have to go. First off, if you have a question, we had one very question, so we're going to start off there. If you have a question, raise your hand. Please stand up, ma'am.
Thank you so much. So I did have a question in regards to lung cancer screening in particular. And I have a history. My mother and my grandmother have a history with my mom and my grandmom having lung cancer. So with that being said, I found out later on in the program that I don't qualify because I'm not a smoker, and I don't meet the qualifications. But by me not meeting the qualifications, I guess my concern is I still want to be screened. I still want to know because I have a history of the disease. So what steps would you recommend?
And so this addresses several points. Number one, we talked about radon. Two, if you're a person exposed to secondhand smoking. Three, one of the issues which you touched upon, environmental impact that can give rise to lung cancer. So can you get a screening done, and do we have to then pay for it, or is it something that's still going to be covered? Thank you very much. Is that okay? Yes. Go ahead, please.
So I'll start. I think officially, you wouldn't qualify for the screening as the guidelines have recommended. And the challenge is that a lot of the hospital systems, one, if they screen outside of a certain number, that they can lose their program, their screening program. And the other part is it might not be reimbursed. What you can do is have a discussion with your primary care physician. Explain to them all of the risk factors that you have or the things that you think are related. And although it might not be screening, you might be someone that's, okay, maybe a chest x-ray could suffice given on the information that you give them. But I would communicate with them along those lines.
Yes, please, go ahead. Take the microphone.
So one other thing to follow up with that. So there are different screening guidelines, and the insurance company uses the U.S. Preventative Services Task Force screening guidelines. That's the one that focuses on smoking. But there's something called NCCN, which is the, I'm blanking all the,
National Coalition Cancer Network.
Yes. Those screening guidelines do actually have radon, included there. And so, and there's American Cancer Society. But the issue is the reimbursement happens with the USPSF. But if you needed more evidence, right, of at least a reputable guideline that people listen to, oncologists look at NCCN guidelines.
How much do the low-dose lung cancer CT, how much do the low-dose CT scans cost? Anybody know? Top of your head?
So I know
Expensive.
for people that qualify due to lack of funding or whatever, our hospital's offering it about $100, about $90-something. So there are assistance programs if you do qualify.
If you can't get. All right, thank you very much. Please, go ahead.
Hi, I'm a 15-year lung cancer survivor. Thank you. And I've had radon testing twice in my house, but my husband died of lung cancer, and I was always curious, what's the likelihood of two people in the same household of getting lung cancer? One survives and one doesn't.
Dr. Flano, thank you very much. Thank you very much.
So although we know, if your test for radon is low or underneath the safety, there's still certain levels that factor in. That would probably take a little deeper dive into figuring out other things that could be contributing. Is there tobacco use history? Is it a secondhand smoke contribution, a third-hand smoke contribution, exposure to asbestos or any other areas of the country that you live for, and family history? A lot of times people will say, well, my grandfather died of cancer, but they were smokers. But we don't look into that deep enough to say, okay, yeah, we know that, but was there something else contributing that increased that risk? And those are things to go through, speak with, again, primary care doctors, outline the family history and everything, and then go from there.
Go ahead, please.
So I'm the little sister here. I'm going to say another piece, and I study this at Fox Chase, is how well people fix damages to the DNA, right? So you can be exposed to radon, you can smoke. Some of us are just good at, gluing it back together once it's broke, and that ties into your risk too, right? So we know that if you do have those differences, in our Never Smoker Clinic, we're actually working on an assay that we can take a little bit of your blood and see how well you are at fixing that damage, right? So what that means is when you think about your risk, you may want to take some of those healthier behaviors. And one thing about radon, it's not a one and done too, right? It changes throughout the year, right? And so you have to test every 2 years actually continually, because there are times where the radon can come back in even if you've had a mitigated home, right? So that's just another thing to think too. Oh, same. It does. That's where he actually figured
Point that was
out.
made was she's living in Montgomery County. She says that that has some of the highest levels of radon in the area. Talk about also real quickly though, since you mentioned about mitigating, in Pennsylvania, do you have to be certified, and how do you tell you got a good group that's coming to do it?
That's a great question.
Thank
So
you.
if you go to if you go to the Pennsylvania Department of Environmental Protection, on the website, we have a list of all the certified testers and all the certified mitigators, right? In fact, we have a list of, I guess, friendly testers and mitigators. So if you want that, but we can forward that. But we actually put it as a PDF on the website. They update it every year.
So, Noah, would you answer something for us, though, before you comment? We're talking about lung cancer screening. We know about colorectal cancer and all that. But there is something, called coronary calcium scan. How important is that, particularly in what you talked about as far as our lipid profile and determining our risk for heart disease?
Actually, coronary calcium score has emerged as one of the key determinants of early diagnosis of atherosclerotic heart disease. Again, stemming on the fact that if there's inflammation, a lot of times calcium will be deposited in the arteries, causing the hardening of the arteries. And that is the definition for atherosclerotic heart disease, coronary disease. The basis is calcification. And you get calcification, again, when the artery gets inflamed, when there's irritation of the artery. Over time, calcium from the blood deposits in the wall of the artery. So you may be asymptomatic. Again, that you may not have any symptoms, but that's one of the ways that we can detect early on that there is inflammation, there is fire in the wall of the artery, and so that we can intervene sooner than later. So that's a great question. And again, to go back to, I wanted to comment on the last question about two people in the same household. One survived, one did not. Again, it could be on the basis of what other factors are contributing to the inflammation, to the inflammatory milieu, right? So there could be diabetes, there could be hyperlipidemia, there could be maybe other risk factors that probably put the other person at a higher cardiovascular risk, and such that can be the leading contributor to the mortality that we're seeing. And so much so, people are living longer now. People are surviving cancer. And so we find that a lot of times they come to my office, the cancer have been in remission for a number of years, and now they're dealing with the heart disease and the stroke. So be mindful of your numbers. And so that's how you're able to really counteract not only cancer, but also heart disease.
Kathleen, I want you to put your navigator hat on for me, because one of the important things we hear about now, and has been alluded to, is zip code should not be a determinant of your risk for dying. So when you're looking at things that are impacting people who have coming down with cancer, lung cancer, and how that may affect them, do you take this into account of where people may live? And also, I'm going to get Brian to comment in looking at our AI models. How does that come in as we look at determining factors for increased risk for people?
I think right now in navigation, the work is so, I don't want to say overwhelming. Oh, sorry. I don't want to say overwhelming, but, we're helping so many patients. I mean, we definitely look at zip code for the services that we offer. And the things that we do and what we assess for. We do a much more in-depth assessment for some zip codes than we do for others, knowing kind of what we know about that area, the lack of resources in an area so that we can provide more to them.
Brian, so when you're looking at your model, we've already heard that we know that Montgomery County area has higher radon levels. So how does if we're setting up a model looking for increased risk and or determining how patients may respond, is that factored in?
Well, it's a really good question. Right now, AI is being used in some very specific use cases. And unfortunately, the full set of environmental factors and social and cultural factors is not always accounted for in how models are being developed. That said, what I would say are two things. One, you know, the primary factors of genetics and genetic mutation as the drivers of challenges in treatment for lung cancer are, you know, really incredibly important. That data is only about 10 years old. Like, so people that have had a family history where someone died of lung cancer over a decade ago, the care teams, the doctors, we, clinicians, researchers, did not have access to genetic data for their type of tumor, right? That's critically important. So don't always just go on a past basis of thinking how a risk factor affects you. Similar to radon, right? Radon's fairly new, radon's not new. Our understanding of how radon affects the development of various types of cancer and then its progression is relatively new, and the research basis is not good for this at all. So there are some models that can incorporate some of these environmental factors much better than we're able to do through traditional research. I think that for me, from a research perspective, the thing that's most important about AI that's going to be changing in the next decade is we can develop models using things of what we call digital twins, right? So we can create a twin of a patient or a set of patient conditions and test against that digital model instead of the patient as a way of experimenting and seeing the impact of something like an environmental factor, like radon exposure, within the other factors. And that's that accelerates the research dramatically so that we could have new treatments perhaps in 3 years instead of 10 years, right? So this is one of the powers of AI. It's forward-looking. It's not a guarantee right now. Okay. Now, in terms of the locality of radon, yes, there are certain places where we know that radon is much higher.
But does it factor? The real question is, does it factor
environmental?
Into, okay.
And we can calculate that in, but I'm saying all I'll say is like it's the data's not good enough to us.
You have your homework, sir. You have your homework.
Specify.
Let's take this question before that. Go ahead.
Hi, thank you. My name is Katerina. I have a question when it comes to lung cancer screening. So we know that younger people are getting lung cancer. We also know that a large part of lung cancer patients are not eligible for that lung cancer screening. They don't hit that age requirement. Do you see in the future the eligibility criteria for lung cancer screening widening?
Yes.
Go ahead, Dirk.
Yeah, 100%. So remember, lung cancer screening is one of the newer established screening guidelines that's coming. And there are 3 papers that came out after lung cancer screening came out. 2 came out of Tennessee, and then 1 we actually published from our institution. The guidelines were set forth as supposed to be a one-size-fits-all. What we found, specifically in our institution, is we were missing a large population. We have a large African-American population that we're screening. 16% of them were underneath the screening requirement age. 11% were underneath. Another 5% were of the age. So they didn't even, that we knew they had cancer, they didn't even have the opportunity to get screened. So we published that, along with those other 3 papers. The criteria changed, and they dropped the age and they dropped the smoking requirements. We see that continuing on. The more people get screened, the more we get diagnosis, the more we track it with models, with AI models, to see where the bell curve rises and falls so we can catch everybody underneath. I expect the criteria to change even more. So it's a process, ongoing. Expect it to change.
This is going to be our last question. Then we're going to come back, and I want a take-home point from each one of the panelists. And because of what Shamika started us off with, from looking at it from the patient's perspective, what are the things we should be doing? But first, this question.
Yeah, I have a question. You mentioned something about you get lung cancer smoking cannabis.
Yes.
You can?
Oh, smoking cannabis?
Yeah.
Yes, absolutely. The risk, if you're a heavy user, the risk goes twofold in a lifetime to develop it. When that's 50 times use in a lifetime, you know. So yes, it's been well documented now. You know, it's not filtered. People roll it themselves. We don't know how they're rolling it. It's nice and fat.
And you also don't know what else is in there. Khadijah, I know you want to jump on that one. You wanted to say something on that.
No, I was talking about young adults. I just real quick wanted to talk about young adult. Our programs are having young adult cancer programs, right? So I think that part is important, at least to the evidence-based change, like we said, where we can make those rules. I get that question about cannabis all the time. Of course, heavy use. And also vaping, right? So the one thing I just want to talk about, this whole dual use thing. If you look at individuals who use combustible cigarettes, non-combustible cigarettes, and also cannabis or any other thing, your lungs are under attack. That's the bottom line. You're jumping them, right? It's just like two gangs coming together. And so even though alone it may be okay, you can survive the fight, but with all of them, eventually you're going to have a busted vessel, right? And so I think you have to think about that exposure. The data shows that African Americans, if you look at people who would be dual users of multiple products, 50% of those are African American, right? So we have to really think about the compounding of that.
All right, so let's take the final comment. 1 minute. I want a 1 minute response. Since start off with you, Kathleen. We're going to come to you, Khadijah. Then you, Brian. Then you, Dr. Sloan. And then you get to tell us if we're all full of crap, because we're talking about from the patient's perspective. All right. So go ahead.
Okay.
What is it that we should be doing from that patient's perspective?
Advocate for yourself. No one is going to take better care of you than you or your loved one. Don't be afraid to ask questions. Don't be afraid to insist. Don't be afraid to offend. You ask the questions. That's what we're here for. You should never get pushback on getting a second opinion. We understand that we don't want to wait and do all of those things, but if you have everything in hand and you want to get a second opinion, no one should make you feel guilty for that or feel like you won't be able to come back and get care for them if you seek a second opinion.
And I want to remind everyone, there's lunch after we finish all this, and the folks will still be around. So do ask particular questions. If you have another question, you don't want to ask it up in front, or because I ran past you and I didn't get to you. But they will be around for a little longer and get some more questions.
Oh,
all
wait,
right?
I had one more thing, too.
No more questions.
You are not your history. So when my navigators look, and this is controversial, we don't even ask about smoking history. Our navigators don't anymore when we're working with patients, because I feel like the minute we ask, there's an assumption that there's some judgment on our part. So we have a lot of clinical people. They ask that question for us, but we don't even ask it anymore. And I think Khadijah did great in pointing out that we know a lot more now.
I would say don't self-blame, know your risk, and take action. So there's enough. I brought 100 test kits, radon test kits for free over door. Take one and take one, you're welcome. Take one and take one for a friend, right? So it could save your life or your neighbors.
So this doesn't just go for AI, but for patients and how we ensure that healthcare is always patient-centric. The number one thing is listening to patients. Healthcare providers always need to listen, but that unfortunately flips it back to us as patients, right? We have to know how to frame questions, how to ask the right questions, not be afraid to ask questions, not be afraid to push back if you don't understand an answer or frankly don't like an answer, right? Because people talked about the importance of shared decision-making. It's your care, it's your health, it's your lungs, right? So that's why you need to be an equal partner in making those decisions for yourself and bringing in your family as needed as well. I think that AI does empower us better as individuals, as patients, because if nothing else, AI listens and does mirror human empathy. Now, the other drawbacks that it comes with, I'm building AI that will not diagnose a patient. Doctors still diagnose. It will not recommended treatment to a patient directly. It's through a doctor. So there needs to be clear guardrails when we use AI, and that's important. And that's why I said ask your care teams, if they're using AI, to explain to you how they're using it, why they're using it, and how it's going to help your care.
I would say we cannot get ahead of these, some of these diseases. We cannot make our lives better through healthcare without having what we call health literacy, an understanding of what's being told to you, an understanding of what's available to you, and then advocating for yourself to get down that pathway.
Thank you. And listening to what everyone has said here on the panel, including myself, knowledge is power. So I think it's very powerful for you to have been here today to listen and be thoughtful of sharing this information with your family and friends, dispelling anything that may not be true for them so that they can also be here in the long term. This is about prolonging your life, prolonging the time that you're here with your family and your friends, and having the great ability to just live life well. In addition to that, patient advocate and having the patient navigator there with you, I think is really powerful. I think this is something that I didn't talk about, but I also think it is important to have, if not a patient advocate with you, a navigator with you, to have a family member with you, somebody who is listening, someone who is there with you. So if you have to go through this journey, don't go through the journey alone, whether you're using a patient navigator or a family, friend, church family member with you. Please have somebody with you to help you go through the journey, because you're not alone. You just have to tap into the right resources to do so. So thank you, everyone here. I appreciate you all the work that you have done and continue to do on behalf of lung cancer.
Let's give a hand to our panel, please. I am not going to put any pressure on Dr. Morris, but the last thing that's standing between you and lunch. All right? But remember, though, in all seriousness, thank you all very much for coming out with us today. Remember, the information is on the website. Please, you can go there, take a look at it. Share the information. Care Access folks about there, I cannot tell you how generous that is of having the radon. I got to give you a hand again. Bringing the radon tester, that is above and beyond. And that is just outstanding. That is just outstanding. Get it, use it. It'll protect the family, protect you. And by all means, do share the information. Now, again, lunch.
Can we just once more give the panel a hand? When you think about their busy lives and their work schedules, they took the time to come out and see you. And give yourself a hand. Thank you all so much for being here today. I wanted to just also follow up. Care Access, he mentioned screening for renal, but they are screening for renal. They are screening for cardiac. They are screening for diabetes. And this is free screening for you. So please take the time to visit them, and you will get a gift card just for allowing them to take your blood. All right, so where the lunch is in our fellowship hall. We also have some vendors there with more information. That's where you can get your radon kits. Dr. Corey Ellis has some information, and some of our other speakers. Thank you all so much.
It is always a pleasure.